Okay, welcome everybody for this webinar. It is my pleasure and honor to introduce Professor Bhavuk Garg. As you can see, he is a young faculty at from AIMS, New Delhi. Professor Garg is an orthopedist and has a high level of academic accomplishment, which I am going to enumerate. And it is indeed very high level of accomplishment for his age. Professor Garg did his MS from AIMS, New Delhi. I actually came in contact with Professor Garg through the Indian Society of Bone Mineral Research discussion forum. In this web-based forum, I think some 3 years back, I uploaded our paper describing the preclinical efficacy of oral pentoxifylline, a phosphodiesterase inhibitor, in a manner similar to teriparatide. And I was looking for a clinical researchers to take up a trial in postmenopausal women. I was surprised that within minutes of uploading it, Bhavuk emailed me showing his interest. He then submitted a grant to DHR on it, and it has been funded. And unfortunately, starting the trial, however, got delayed due to COVID, but it is about to get started, and we are eagerly waiting for the outcomes. Now, about Professor Garg's research. His research encompasses cutting-edge topics, really speaking, very cutting-edge topics, including study of complex spinal deformities, degenerative spine and infection, robotics and minimal invasive surgery, AI and biodesign. Particularly given his expertise in biodesign, Professor Garg also serves as a faculty of International Institute of Biodesign. He is a pioneer in 3D printing in spine surgery in India and supervises 3D gait analysis and orthopedic genetics lab. Professor Garg holds numerous prestigious national and international fellowships and has so far won 38 awards. To name some of his awards that fall in the realm of CSIR's mission of technology development include DBT Innovative Young Biotechnologist Award, Gandhian Young Technological Innovation Award, Asia Pacific Mimics Innovation Award, and most recently, just last year, DBT Biotech Product Process Award. He also holds numerous prestigious positions in the capacity of advisor and member of National Task Force. Professor Garg has a prolific publication record with nearly 300 papers, 40 book chapters written. He has written 2 books, and he also is an inventor of 3 patents. With this brief description of his academic eminence, let me formally invite Professor Garg to deliver this webinar.
Thank you, Professor Nabedia. Thank you for the kind introduction. And I thank Professor Nabedia for giving me this opportunity to talk about our research, the research which is related to the osteoporosis, which might be of interest to your domain, the people who are attending this talk. So at the start, I must thank you all who are spending their time on a Saturday leisure evening. So this is the basis. We published a paper in 2019 regarding the management of fragility fractures in India, and this is a paper which has looked at the various aspects related to fragility fractures and the I would rather say the sorry state of affairs related to management of these fractures in India, and how they are neglected, how they are not properly taken care of. And one of the basic cause remains the lack of understanding of the basic science behind this problem, the osteoporosis. And if you look at the India comprises of 2.4% of the world's land area, and just 2.4%, and which is occupied by 17.5% of the population. So there is a huge mismatch between our resources and the population. If we look at some incredible facts about India, about 45 lakh Indian women. These are some modest estimate. I believe the figures are much higher. About 45 lakhs Indian women above 60 have a fractured spine. 2.5 lakh Indian patients they suffer osteoporotic fractures every year. And vitamin D deficiency is a key factor which is influencing the bone health of the Indians. And the most of these fractures are never investigated for osteoporosis, and therefore they are never treated for the cause. We know that our modest estimate again they are that 61 million Indians they suffer from osteoporosis, and out of these people, the 80% they are women. And on the global basis, if we look at the Indians, they have got the highest prevalence of osteopenia, which is related to various factors which we can discuss, maybe dietary factors, maybe the dark skin. There are various factors. Compared to Caucasians, the osteoporotic fractures in the Indian population, they occur 10 to 12 years earlier in the age. So again, the disease burden is very high. The fracture itself, they are more common in Indian men than in the Western population. And why is it more serious? Because it affects many more women than the heart attacks, strokes, and the breast cancer altogether affect the women. And the osteoporosis basically kills a man by its complication. And they reduces the sufferer's life expectancy by a decade. So when we talk about hip fractures, when we talk about spine fractures, we talk about the 30-day mortality rate, we talk about the 1-year mortality rate. So that's how the serious the problem is. And they are also very expensive to treat. The surgical treatment and even the medical treatment of these fractures is quite high. So you can just see, if you look at the disability adjusted life years, the osteoporotic fractures, they are a major cause of, the burden of disability. Worldwide, around 8.9 million fragility fractures occur every year. And the hip fractures alone, they are projected that they are going to rise by 310 to 240% in women by 2050. And the reason is because our population is aging. Our life expectancy has increased, and that's why these fractures they're going to increase. And if you look at the hip fractures, the forearm fractures, and the vertebral fractures, they all have shown, there are various literature, they have shown that as the age advances, their incidence also increases. So there is a clear-cut relationship between the age and the incidence of these fractures. And these fractures, as I told you, that by in coming next 20 30 years, they are going to increase exponentially because of the increased life expectancy. And this is if you look at the data of the hip fractures in India, in public hospitals, the majority of these fractures are treated in the public hospital, and the cost remains very high, especially in private setup for these patients. And this is again the hip fractures, they are associated with increased morbidity and mortality, and this can range from complete dependence upon the other person to also the death in a very short time. The mortality after hip fractures is 1-year mortality is between 15 to 50%, and it also affected by the timing of surgery. And again, the one fracture begets another fracture. So this is also important to understand that it is just a sign of osteoporosis at one bone, but basically osteoporosis is systemic disease. So these patients, they often suffer from other fractures very soon once they suffer from the other fractures. So vertebral fractures also, if you look at the spine, again they are very common in Indian population, and more than the 15 to 20% of the urban adults, they show at least one vertebral fractures. And these vertebral fractures, they cause spine deformity, they cause pain, they can impair the function, they decrease mobility. And when the mobility is decreased, it leads to more bone loss, which is again a vicious circle. And it also affects the when the person bends forward, his or her abdomen is compressed, so her appetite is also is less. And then these patients, they also develop sleep disorders. So this is like a vicious circle. So once the back pain starts, it leads to spinal deformity, then decreased lung capacity, then impaired function, the sleeping problems. Again, it's lead to depression and all those things, and this is a vicious circle. So if we look at the relative risk of death after an osteoporotic fractures, it is 7 times higher after hip fractures, and it is 8.6 times higher after spine fractures. Why as Indians we are more susceptible? We need to understand the basic cause because we don't drink enough milk as children. It may not be true for the rural areas, but it is very true for the urban areas. There is higher incidence of varied degrees of lactose intolerance in Indian population. Rice is the major, the major source of food at various places, and it is a very poor source of calcium. The vegetarian diets and cereals, they have low bioavailability of calcium. Vitamin D deficiency is very common. Protein intake is poor. We take excess salt, so it also increases our urinary loss of calcium. We don't follow, the majority of people not follow the healthy exercise, and our BMD, as you know, as a baseline also is less as compared to the Western population. The osteoporosis is more common in thin women, so in women the BMI is relatively lower in Indian population, and late menarche in girls, so there is a low estrogen exposure is also common in India. And there are certain peculiar hurdles in India. There are socio-economical problems. The hygiene is poor. The people tend to get treated by quacks and the bone setters, and the financially, most of these elderly, they are dependent upon their children. The rampant vitamin D deficiency is well reported in the literature, and we have seen in various people that this deficiency is common in children and as well as in adults. And the lower BMD, the cause of lower BMD in Indian population has been cited. The genetic causes, the smaller skeletal size, nutritional or the lower education, poverty, illiteracy, misbelief, addictions, population explosions. We don't have the sufficient diagnostic facilities. So all these, they tend to enhance the impact of osteoporosis in Indian population. We have also published, regarding the non-surgical options, and people, they often go for indigenous braces. And this is the paper, which was published in the Archives of Osteoporosis, in which we looked at the various current practices, barriers, and facilitators to improve this thing. One of the major factor was that we don't have enough diagnostic facilities in India. Rural setups, again, it is a major concern. They don't have facilities, and once even you have diagnosis of osteoporosis worldwide, there is no method by which we can see the efficacy of these drugs. We just get the DEXA scan done as a diagnostic modality, but again, the effect on DEXA scan is not visualized at least at the end of 2 years. So we need at least 2 years DEXA scan to see any effect of a drug which is having or not. Also, the many drugs, they have shown that, like the teriparatide, is not so much effective for the hip fractures. Various clinical studies have shown, but again, there was no the short way to see, which drug is having effect on which portion, whether, the hip fractures, the spine fractures, the radius fractures, they all are common osteoporotic fractures, but all the drugs, they affect similarly bone density at every place, or they have the differential effect on the body, different body parts is not so known clearly. So this is the basically the background about the burden of the osteoporosis and why it is an area of interest to me as an area of research. We know that the osteoporosis is basically, it is a systematic disease which is characterized by the so there is a loss of mineral as well as there is a loss in the structure, microarchitecture structure. So there is a two-way phenomena in the osteoporosis. Basically, we can divide them into certain types. The type 1 is basically the most common one, which is seen in the postmenopausal women because of the estrogen loss, and it basically affects the trabecular bone. While the type 2 occurs in senile or age-related osteoporosis, which usually occurs 70 years of age, and it affects both the cortical and the trabecular bone, and it is multifactorial. The secondary osteoporosis, if some person is having some disease like rheumatoid arthritis, or if he or she is taking some drugs like anti-epileptic drugs, so these also cause the osteoporosis. And then the certain genetic factors, they also cause the osteoporosis. So as I already told you that the goal of pharmacological therapy is to reduce the risk of fractures. So we can use it as a primary prevention when we can, as a prophylaxis we can start, or as we have seen that after one fracture the incidence of other fractures is also high, so we can use it as a secondary prevention also when we give these drugs after the patient has suffered a fractures. So we can divide these drugs into two groups: the antiresorptive drugs. Basically, these are the bisphosphonates, the estrogen agonist, antagonist, calcitonin, denosumab, or we can have the anabolic one. The antiresorptive ones, they do not increase the bone density, but they prevent further loss. and the anabolic is like teriparatide. It's a hormone. So basically, it increases the bone density. It forms the bone. So this is very important to understand that the resorptives they minimize the loss with the bone mineral density which is already formed, while the anabolic one they help to form the bone. So there are various factors which we have already discussed, that besides the bone loss, again in elderly population there is a propensity to fall because of the impaired reflexes, and then they can also cause these fractures. So bone remodeling, we all know that bone remodeling is occurs throughout an individual's lifetime. As the stresses on the bones they change, the formation and the resorption, they keep on balancing each other, and the normal adults they are balancing each other, the completely. While with the onset of menopause or the mid 40s or 50s, the estrogen levels goes down, and then they lead to excessive bone resorption that is not fully compensated by an increase in the bone formation. So that's why these leads to the weakening of the bone, and then it can lead to the various fractures. We have discussed these genetic factors, environmental factors, and the various drugs and diseases. So these are the drugs which we talked about, that there are antiresorptive and the anabolic. You can see clearly that there are a lot of antiresorptive therapies available, while on the anabolic side, we just have teriparatide. There is one strontium renalate also, but it is a very weak anabolic therapy, and it is not routinely preferred. So we talked about the secondary fracture prevention is also important, and now we are starting the fracture liaison services, which looks at the various aspects of improving this thing. So basically, by missing the opportunity to respond to the first fractures, these we are failing to prevent the second subsequent fractures. So coming to teriparatide, teriparatide is a very good agent for improving the bone density, especially for the secondary fracture prevention, and it is basically contains only the amino terminal of human parathyroid hormone. So there are around 180 amino acids in the human parathyroid hormone, and it just contains the 1 to 34 amino acids from the amino side, and it is the first approved and the most commonly used anabolic agent for the treatment of osteoporosis. So this is like the 84 amino acid chain is there in the human parathyroid hormone, and if you look at the amino side, there is a 1 to 34 amino acids. So this is the recombinant parathyroid hormone which we use for these patients, because this is the active part of this thing. So normally, when there is an endogenous parathyroid hormone, whether this thing, it leads to the continuous presence of parathyroid hormone in the serum, and this leads to the increased number and activity of osteoclast, leading to increased bone resorption, and then it makes it causes hypercalcemia and bone loss. However, if we give pulse therapy, that means we are daily giving just 20 micrograms of subcutaneous injections, then it leads to the intermittent presence of parathyroid hormone in the serum, increased number and activity of osteoblast, and then it leads to increased bone formation, which leads to increased BMD, healing of fractures, and the prevention of fractures. So it is important to realize that parathyroid hormone, when present continuously, is harmful for the bone, and while if we give it as a pulse therapy, then it leads to the formation of bone. So it basically, teriparatide hormone binds to the cell membrane receptors, then it leads to various the intermediary pathways, and it increases the insulin-like growth factors, and it activates the osteoblast, and it forms the improves the cortical as well as the trabecular structures. And there is the anabolic window that it usually affects only until 2 years, so we call it the anabolic window. So usually the teriparatide hormone is recommended only for the 2 years. Indications: any postmenopausal women with osteoporosis, increase in for increasing the bone mass in patients, in male patient with primary or the hypogonadal osteoporosis, treatment of men and women associated with glucocorticoid or steroid exposures. And this is just to show you that the teriparatide improves both cortical and the cancellous bone structure. So dose is usually we give 20 micrograms subcutaneous injection daily. There are various other regimes being tried, but they are still in experimental phase. But usually we give 20 micrograms subcutaneous injection daily for 24 months in India. And various studies have shown that they increase the trabecular bone structures at various intervals. If we look at the bone strength and compare it with the antiresorptives and the anabolic thing, we can see that the bone strength actually is increased by anabolic, while the antiresorptive just make it to stay there only. So this we have already discussed. So there are various, the stimulators and the inhibitors are available, which are affected by these hormones. Interplay is there. So I'm not going to detail. There are various genetics is involved. Coming to diagnostic modalities. So how do we identify the osteoporosis? The standard is the DEXA scan, which is the dual energy X-ray absorptiometry. We have the other measures like quantitative computed tomography or CT. Plain X-rays we can also diagnose, but again the bus is already missed because at least 30% bone is lost when the osteoporosis is visible on the X-rays. They are all anatomical imaging tools. We do not know the physiological or the functional this thing. So when we give any drug to these patients, how they are behaving, how they are improving the bone strength, we don't know. So we just have the static landmarks that we have a DEXA scan at the start of the therapy, and then we have to wait at least 2 years to see whether the drug has worked or not in those patients, because the DEXA scan, it doesn't show any improvement before the at least 2 years of treatment. Coming to bone scan, the bone scan is a form of functional imaging tool. It looks at the pathophysiology of the metabolic bone disease, and it can be used to monitor the real-time treatment response. So this was our study area, and the bone scan, it also helps to evaluate the regional bone changes. So we can look at so bone scan is basically what we use the a radioactive dye or a radioactive molecule. We use the 99M technetium methylene diphosphonate, and we know that the bisphosphonates, they have high affinity to the calcium molecules to the bone, and they get deposited here, and when they are washed out from the bone, so we can pick up with the help of the radioactive cameras that how they are being taken up and how they are released by the bone, and we can measure that retention, the trace of the radioactive material. So we can also measure the quantitatively the activity, and this plays an important role not only for examining the etiology of the metabolic bone diseases such as osteoporosis, but we can look at the various treatment regimes. We can divide the bone scan into several areas, and we can look at which area is being more affected by which drug. So this bone scan, the quantitative bone scan imaging, has a useful role in the research, where we can examine the pathophysiology of metabolic bone diseases. We can look at how these patients, they are responding to various treatment regimes, and we can measure the kinetics of this 99M technetium based on a standard bone scan. We can measure how rapidly or how slowly this tracer is being cleared by the plasma from this bone scan image, and this is known as the whole body retention test, which we do. This is specific to the nuclear medicine people, and we can measure these K bone values, because this K bone is basically, it shows that how much faster or slowly this this tracer is being cleared from the bone into the blood. We can also measure various bone turnover markers, but they are very costly affairs. They are surrogate markers. They are not the exact thing that how much bone is being formed or useful. So, but they also have a role in the monitoring of the treatment. So there is a paucity of data. So the two major drugs which are used in the treatment are teriparatide and the alendronate. Teriparatide is anabolic, and the alendronate is the antiresorptive. And this is why we kept this rationale as a potential research question in our study. So this study was funded by the ICMR, and we started this in 2015. We finished in 2018, and this was a comparative experimental study. It was a pilot study, and it was a randomized study. We looked at the safety and efficacy of the teriparatide and alendronate for the management of the postmenopausal osteoporosis. And our aims were to establish the role of this quantitative bone scan in the management of osteoporosis, and we also looked at whether this teriparatide or the alendronate, they have some region-specific anti-osteoporotic effect or not. So because we don't have any data worldwide among this relative efficacy of these teriparatide and alendronate, since we are having the aging baby boom, so again this becomes an important area to identify. To compare, and these were the objectives, to compare and analyze the visual changes in the whole body scan patient who are receiving the alendronate or the teriparatide, and we looked at the various intervals, and then we looked at the quantification of the region-specific anti-osteoporotic effect of both the drugs. These were our standard, the inclusion criterias. We excluded with drugs or any secondary diseases or cancers or the fractures. We got an approval from our institutional ethics committee. So we included around 36 postmenopausal women in this thing. We used the standard diagnostic criteria with the help of the DEXA. We followed them regularly at different this thing. And after the first follow-up, we lost around 4 patients in each group because of various causes. So ultimately, we had 28 patients in each group. They were subjected to detailed, the performa with the help of, the detailed clinical history and examination. So we had around total of 18 patients were allotted in each arms, and all the patients, they were prescribed the standard treatment therapy like alendronate. We give 70 milligram once a week, or teriparatide we give 20 microgram percutaneous daily. We withdraw the blood around 10 ml at a standard time, as mandated by the manufacturer's protocol for measuring different blood bone turnover markers. Uh, we looked at the in the urine as well, and then we measure all these the laboratory parameters in the form of the hormones and the bone turnover markers, and we use the standard gamma camera for the 99 mm technetium scan, and we looked at the various this thing. So we injected women with 600 millibacterial units, and we took the diagnostic bone scan at 3.5 hours, and we also took the 10 minutes, 1 hour, 2 hour, 3 hours, and 4 hours, and we looked at these K bone values in the different thing, and we divided the whole skeleton into 6 regions. We looked at the calvarium, skull. We looked at the mandible, we looked at the spine, pelvis, the upper extremity, and the lower extremity, and then we combined them, and we looked at the whole skeleton as well. So one of the four major bone specific, the bone turnover markers we looked at. The two were the bone formation markers, and 2 markers we took as the bone resorption markers. And we used the standard statistical analysis with the help of our statistician. This is sort of consort diagram, this thing of our study. So as a result, we found that demographically, both the groups, they were all equal. The laboratory markers, the BMD, and they were all uniformly distributed. There was no significant difference in any the bone marker values in different times in both the groups. So again, they showed that there is no major difference between these two drugs when we looked at this thing. However, when we looked at these the bone scan values, we could find certain differences. We could see that the teriparatide increases the bone mineral density or the activity at the skull. The lower extremities, again, it is better with teriparatide. The whole skeleton values, they are better with teriparatide. This is just to show you an example. Like if you can see that there is a significant increase. You can compare it with the 0-day and the 3 months values with the help of in the spine. Also, you can see that the density has increased, or the pickup of the scan has increased. And again, at 18 months, you can see that there is a significant increase in the spine as compared to the baseline. With alendronate, majority of the areas there is no change. However, in lower extremity we could find some changes, while at the 18 months we could see only mild increase in the most of the places. So no side effect was seen during the study. We couldn't see any fracture events. Both the drugs were well tolerated. The economic burden of teriparatide is higher as compared to alendronate, and we didn't find any correlation between the bone turnover markers and the regional bone scan sites. So this we have already discussed. So the values of bone scan at different skeletal sites, they were higher with teriparatide, but they were not statistically significant. However, regions at lower extremity and the whole skeleton sites, they showed that the figures were statistically significant with teriparatide. Overall, the teriparatide and alendronate, they provide a comparable results, but teriparatide therapy seems to be moderately better than alendronate for the improvement at specific regional bone sites, including the whole skeleton. However, it is too early. We need a larger sample size to substantiate our claims. And the alendronate is also ineffective and affordable, and thus may be kept preferred among population for the treatment of osteoporosis. There were some limitations also in our study. The translationally potential is that we can look at the regional specific efficacy of the teriparatide, and this has also enhanced our understanding of bone scan as a diagnostic and prognostic modalities, and we can use the domain-wise use of bone scan in the management of osteoporosis. And this is this study might be useful for the experts working in periphery or the limited resources. We can choose our drugs based upon a patient specific treatment, and the findings may also be helpful while we are treating the osteoporosis specific bone sites. We could get the best paper award for this study in SECON 2018, and after the study, I came into collaboration with Dr. Nebedia, and we got a lead to go ahead to find a substitute for teriparatide, because we know the economic burden of teriparatide is high. Teriparatide is injectable and it requires proper storage. And the 54% of the Indian population, they don't have access to the refrigerator to keep the drug. The minimal treatment cost of teriparatide is around 7,000 rupees per month. So Dr. Navedya proved that the pentoxifylline is again a very good drug for the treatment of, which is commonly used for the treatment of intermittent claudication. So he has shown that it stimulates the bone formation in osteopenic rabbits. So therefore, we are attempting a comparative study now between the oral pentoxifylline and the conventional teriparatide for the treatment of postmenopausal osteoporosis. And so this is our research question: whether the oral pentoxifylline is capable of optimizing the osteoporosis treatment than teriparatide. And we don't have any oral drug right now. And if we can, so it's sort of drug repurposing when we are having a known drug, and then we can use it for treating the other diseases. So this is a randomized controlled trial, phase 2 trial. Study duration is 2 years. The funding agency is the ICMR, and this is the study team. We have the endocrinologist, and we have the Professor Rajesh Malhotra, who is the chief of our department, and Dr. Navedya from the CSIR CTRI. We are going to look at the safety and efficacy of oral pentoxifylline, and we are going to analyze the status and the gain of BMD and the bone turnover markers in patients treated with pentoxifylline. And then we are going to compare the BMD gain and the bone turnover markers in patients who are going to be treated with the oral PTX and the injectable teriparatide. So we have planned right now in 90 patients this study. So we are going to have 3 groups. In one group, we are just going to give the teriparatide. In one group, we are going to give the pentoxifylline 800 milligram, and in one, we are going to give just 400 milligram. And then we are going to see the different this thing. So if the relevance is, it's a pro-poor innovation, because it will drastically curtail the cost of PMO treatment, and the cost of PTX will cost around 1,100 rupees per month as compared to 7,000 rupees with teriparatide, and it doesn't require any special storage. So again, this is going to be a additional gain. So this is just a brief of our study, that how we are going to do randomization and the BMD, and this is all the standard one. Primary endpoint will be our BMD at 12 months, and the secondary endpoints will be to compare with teriparatide, and we are going to use the standard, the randomization this thing. This is the reference study of Professor Navedya, which we are talking about. On the basis of this thing, we have designed this study. I'm thankful to the ICMR for granting us the grant for funding this study. And these are our co-investigators for the bone scan study: Professor Rakesh Kumar, Dr. Sudeep Sen, and Girish Parida and Him Chandra. Thank you all. Thank you. I can take questions if anybody has.
Yeah, it was a short, succinct, but very nicely explained webinar. I'm sure people will have questions, but for my understanding, I would start seeking clarification. Is that in your, if I have understood correctly, that labeled MDP, technetium labeled MDP, that is a sort of a bisphosphonate-like compound, you said, right? So my question is that since in the gamma camera imaging, you are seeing less of MDP on bone in the alendronate cohort compared to teriparatide, can we assume that suppose alendronate also has a high affinity to bone, so the cold bisphosphonate lying there, is it possible that your labeled bisphosphonate is not getting the place to bind, and that is the reason you are not getting a difference or are getting a less labeling of bone compared to teriparatide?
Yeah, so this bisphosphonate, they have preferential binding to the bone, but actually the radioactive dye which we are using, it is basically denoting the excess activity in the bone. When the bone formation is going on there, so it is actually washing out there. So so you rightly said the alendronate binds with the bone, but it is this radioactive activity is not related to the binding of to the bone. It is related to the clearing of the radioactive dye from there. So it is not related to binding to the bone. So that's why it's very short. We are just getting it 1 hour, 2 hour, 3 hours window.
And another thing is that your endpoint was 18 months, right? This
18
study
months, yes.
18 months. And so you didn't get any increase in PINP or bone specific alkaline phosphatase with teriparatide even up to 18 months?
We got the increase this thing, but it was not statistically significant.
Okay, because of the
And
small
initially,
group.
when we started the study, the teriparatide was approved only for 18 months that time. So
Okay.
okay, but now the in the last 1.5 years, the indications have been changed to 2 years now.
Mhm. Okay, let others ask question. Anybody else want to ask question? Has PGI Chandigarh joined? Is somebody there with a question? Who are the groups? Okay. Well, if there is no,
Hello?
Yeah, go ahead, please.
Hello, sir. This is Chirag here.
Yes, Chirag.
Sir, I have a doubt that you are telling about the radio labeled bisphosphonate, and you will detect it when the radio label dye gets washed. Is
Yeah.
it the principle used in the Tachman probe?
Sorry.
Is it the principle that is used in the Tachman probe? Means when the bisphosphonate will add to the bone, then the radio label dye will be detached from it, or is it something different?
I think it is something different. I'm not the right person to answer these technical details because Dr. Rakesh Kumar from nuclear medicine, he handled this thing. But as far as I understood and we analyzed the imaging, the radioactive dye, it gradually washes out from this thing, and it also only depends upon the ongoing bone formation activity at that area.
Okay. So when there is bone formation at a specific site, then only the dye will wash.
Then
Okay.
only the dye will show there, the activity will be picked up there. So basically they measure the renal excretion, they measure the whole bone values and this thing. So on the basis of this whole thing, they give us the proper K bone value.
Okay. I have a
So
second question, that the bisphosphonate will bind to the bone, and due to remodeling,
yes,
right? Due to remodeling, the dye will be washed and it will be detected in the fluids, right?
yes.
It is a principle that only.
Yes. See,
Okay.
there are two, three things. The bone scan as such right now is used only as a qualitative imaging tools in which we look at the how much dye is showing the activity there. We have gone one step further. We have quantified that effect. We have looked at the how much the dye is being taken by the bones, by how much it is being cleared by the plasma, and how much it is being cleared by the kidneys. And on the basis of there are complex algorithms which is embedded in their system, in their the tool for the nuclear medicine tool, in which they have told us these K bone values, and on the basis of that we have looked at these findings.
Okay. Thanks.
Any other question? If there is no more question, then let us all thank Dr. Bhavuk Garg, and also for your information. that your group is already now within this webinar loop. So every alternate Saturday at 3 p.m. this lecture will take place. Actually, the first one in this phase was delivered by one of your colleagues from AIMS, Rupesh Srivastav,
Yes.
from biotechnology. So also encourage your residents to share their, or you may share their email addresses so that they can be incorporated in this group. And also let me know if you think any potential speaker, particularly young investigator, who can participate in this webinar by giving webinar.
Sure.
So thank you for very much, and we will continue to work with you.
Thank you very much.
Thank you so much.
Thank you. Bye-bye.